My name is Eric Slim. I will be the chair of this session, and I will be chairing this session on operational research. I'm a rehabilitation doctor and did a PhD in leprosy and leprosy-related impairments. I feel quite humble today being the chair, knowing that my co-chair is Dr. Wim van Brakel. Wim has dedicated his life to leprosy and leprosy research and need almost no introduction because of his knowledge on this matter. And he's a member of the steering committee also from the LRI. I think we have three interesting presentations from India, Ghana, and Nigeria. We have 8 minutes per presentation and 6 minutes for discussion and question. Please put your questions, if they are, in the Q&A box and not in the chat box, so that Wim can have a look at them and we can answer or discuss them at the end of the session. Perhaps it's good to start. And the first presentation is by Joydeepa Darlong from India. She is giving a presentation, Understanding Healing After MDT and Leprosy, a Qualitative Study. Go ahead, Joydeepa.
Thank you, Chairs, and a wonderful opportunity for this progress update. And hello to all audience out there. My topic today, the study that we are doing here in India, is a qualitative study, which is addressing healing after multi-drug treatment, centered around perspectives of patients and healthcare providers. And this was a study that was conceived and implemented last year, and the duration is 24 months. This is the team, and the presentation would be in these steps of background, rationale, research question, objective, and design, and the progress till today on the 3 phases of the study. This is my team, and we are very pleased to have like a multidisciplinary and multi-country global team. Along with that, we have a person who is affected by leprosy with lived experiences, who is also a co-PI in this study. This study was conceived because there was a lot of patients in our practice who would come back after finishing MDT, asking whether they were healed, asking whether they would require any more medications, asking whether there was any danger in the coming years, asking whether they are free of disease and also free in their mind to think that the horror of leprosy is behind them. And as clinicians, these questions were difficult to answer because the truth was they could continue to have nerve function impairments, they could have reactions, they could have problems. And it was a contradictory statement to say that they were healed and there was no need of medication. And it was a long journey to tell them and tell people as to what healing meant in leprosy. And hence the study to explore what people thought about it. So the first slide talks about that the challenges continue as disabilities, grade 2 disability, the visible deformities, and the burden of the disease could be a lot, which people continue to live on with disabilities, and that gets cumulative every year. And complications like type 1, type 2 neuropathic pain, health-related quality of life, economic hardships, out-of-pocket expenditures, stigma, discrimination, exclusion are all a part and parcel of people who complete MDT, a section of people who complete MDT. So when we talk about cure, medical professionals say that you have taken 12 months of MDT, you are cured. And patient is never satisfied with that answer. So we know that currently leprosy care is like an episodic model. A person comes with reaction, we treat the patient for a few months and send the patient home. Or he comes with a disability, we teach self-care, or we ask them to undergo reconstructive surgery. So it's all very acute and episodic model. However, the recent studies say that we need to have more of holistic care packages. And in the cure in leprosy actually extends beyond the absence of disease. It's just not the physical, but there is also the other aspects of a person's life that could be affected with the disease processes. So in chronically ill patients, there is an approach which could be holistic or comprehensive. So this healing model goes beyond symptom management. And looking at other similar chronic diseases like TB, diabetes, mental health, illness, and HIV, there are patients who continue to live with problems, but they live meaningful lives. And so this is the aspect that we wanted to explore in the realm of leprosy, and hence to offer a healing model that would go beyond the episodic symptom management. So the research question was, what do patients and what do healthcare providers think or know or have an opinion on what the chronic, about living with chronic aspects of leprosy? And after that, can we formulate a guideline that could address care after MDT in such patients? So our objectives were the same. First, we would draw lessons from diseases that were similar to leprosy in terms of chronicity, in terms of stigma, pharmacy, like multiple drugs to be taken, long self-cares to be done. So to do a literature review, and then to understand what patients are talking, what are they saying as what healing means to them, and what the healthcare provider thinks that healing being offered to the patients, to understand it through a formative research. And synthesizing the two for phase 1 and phase 2, we would develop a care after cure guideline that would be co-produced along with persons with leprosy. So we decided to have the study site in a state in India, which is one of the highest burden of leprosy, and also a very rural belt with a lot of tribal population. So we decided to take that in central India, Chhattisgarh district. We have Leprosy Mission has a hospital there, and it has all the tertiary care provided in that hospital. We base ourselves there, but the study is being done in the community with patients being interviewed in the community. So the concept was participatory, and person with lived experience is a co-PI who is also helping in doing interviews. The design was in 3 phases, like I said: literature review from these 5 diseases, formative research with 2 groups of people, patient community and healthcare providers. By patient community, we mean patients and also their relatives and healthcare providers. And finally, we would do a FGD with patients and healthcare providers to have the guideline development. So we have completed the first 2 phases of the study, and the analysis of the second stage is almost complete. With that, we were going to start the FGD in the coming days. So we started the study with the concept of framework, which said that there were 3 aspects: medical, social, and mental. And then we went on to do the literature review. From the literature review that we did, the themes that emerged were more beyond what we planned. It went on to social recovery, economic recovery, spiritual and community integration. So these were some of the extra themes that emerged in our framework. And then we had our summaries, which talked about support systems, which talked about supporting having interventions for stigma and social exclusion. Mental health was psychological and emotional health to be supported. Socioeconomic, social relationships were to be seen, and also there was cultural and spiritual beliefs that could be addressed. Then we went on to do the formative research, where we had the series of activities which were data collection tools developed, piloted, expert opinion sought, then ethics was taken. We had to take a repeat ethics in this study, and then we went on to do the interviews with the patients. They were done in the local language of Chhattisgarhi. So we had visualized people in different scenarios: leprosy-affected patients without patches, without residual patches, like after treatment, their patches have disappeared. Some whose patches are still visible, with chronic reactions, type 1 and type 2, grade 1, grade 2 disability, and with secondary impairment like ulcers or contractures. And with the healthcare providers, we had 4 levels: frontline workers, paramedical workers, medical doctors and specialists, and persons in managerial roles and who were the district leprosy and the state leprosy officers. And we had a sample size of 36 in the patients and 14 in healthcare providers, and a total of 50. We prepared a framework and a code book. And then along with that, we had themes in the code book of the provider and the patients, which questioned as to what signifies healing, whether they feel healed or not, what are the reasons they feel healed, not healed, what are their doubts, what is the physical, social, economic, psychological impact, whether healthcare provided was adequate or inadequate, why was it inadequate if it was, what are the gaps that needed to be filled, and what solutions could be provided and who could provide that solution, and any other considerations in the context of healing. So these were the questions that were provided and answers sought. And then this is the third phase of the guideline development, which is yet to happen. This is the plan that we would have 2 FGDs with patients and frontline workers, and the second FGD with healthcare professionals and the policymakers. And then we would have a draft with expert consultation, and finalization of the guideline would be by the end of July. The challenges that that we had were we were dealing with things that were sensitive. We were dealing with things that were close to their heart. Some of them had gone through difficulties, overcome them, and put it in the past. So it was like digging old wounds. So there were people who wouldn't want to refuse to participate, and we honored that decision. And it was difficult interviewing women in rural areas. We cannot, even if it is a woman interviewer, we cannot have her alone. There's always a male member or a female member present, a senior person. So the person cannot speak freely. Hence, there were difficulties when we could see behind in the eyes and the facial expressions, the stories were different from what they were saying to us. So there were a few challenges there. Patients lived far and remote, but it was poorly accessible, but we had to negotiate that. There were elections and we had a lot of turmoil there, so we had to defer our going into the community quite a few times. And however, those challenges were overcome and we could finish the interviews. These are some of our pictures of our teams with inceptions and guideline review process happening. And with that, I end my presentation, and I want to thank the Leprosy Research Initiative and my organization, the Leprosy Mission Trust India. And also the core research is being supported by the Leprosy Mission Great Britain and Effect Hub. So a big thanks to them also. Thank you.
Thank you very much for this interesting presentation. I can't see any questions now, but perhaps Wim has some other information.
No, haven't seen any questions yet. I have a question, if I may.
Yeah, sure.
Thank you, Joydeepa, for this very comprehensive, interesting presentation. I was interested to note that category that you mentioned of spiritual recovery. And I was wondering how that was defined or how you would define that in the context in which you are working.
Yes. The interesting thing was when we were designing the framework at the beginning of our study, we had these 3 aspects, and our consultant, Dr. Rama, who is a very senior professor at the university, she told us to include spiritual dimension, but we were reluctant, and she said, you wait and see, it is going to emerge from your reviews. And sure it did. It came from more in the diabetic papers that we got from the LMIC, where a lot of divine intervention and the hope that is there in the divine, that so there are 2-3 things that came out. One thing was, if anything is happening to me, it's not without his consent, that the divine consent. So it becomes easier to accept. It is easier to think about it as a divine role rather than some bad thing that I have done or the guilt that is there. So that was one thing that came out. The second thing that came out was, whatever happens, I have a hope that the divine, whoever that divine person is, will not want anything bad for me to happen. So even if I'm going through something bad now, the end of the tunnel, there is a light. So the hope that is there comes from the divine belief. So in our context, I mean, in India is a very spiritual country. Whomever you believe, whichever God you believe. So the hope and the guilt, these two things could be addressed by saying that there is hope in a God. And so that's how I'm thinking there are a few more things that would come out, but these are major two aspects that came out.
Thank you. Yeah, that makes very good sense. And we have, in the meantime, two other questions from Dr. Cassandra White. She's an anthropologist from the US. And she's asking, did lack of trust in healthcare facilities play a part in willingness to participate?
Thank you, Dr. White. Well, I wouldn't think that it's a lack of trust in the healthcare facilities, because that came out quite clear that healthcare facilities had failed them because of delayed diagnosis. The unwillingness to participants was mostly because of their own family. They wouldn't want to disclose all that they had gone through and overcome, because there were issues that they had not coped up in front of the spouses or in their own families, but gone to their parents' house. For example, in rural India, if something happens to a woman, most of the time they are asked to go to their mother's house to become okay, to get treated and come back. So the coping, the guilt, the crying, all that would have happened in the mother's house, and she wouldn't want that to be disclosed in front of the husband or in front of the mother-in-law. So it's more or less the unwillingness to speak was because of the disclosure in front of their own families. More so when we saw that the families weren't taking much care of them. If they were very supported, then they would say many things. When they're unsupported, we felt that there was a distrust.
Okay, thank you. Do you have time for another question, or shall we postpone it to later, Wim? What do you think?
I think we could move on and do this follow-up question at the end.
Okay, thank you. Then we go on with the next presentation from Frederick Selorm Tsikpor from Ghana, who will be presenting a paper on the role of person affected as agent of change in their community, leprosy peer mentors to support case detection, DMDI, and stigma reduction. Please go ahead, Frederick.
So my name is Frederick Selorm Tsikpor from the National Leprosy Control Program in Ghana, and I'll be presenting on the leprosy peer mentor study. I started this research back in March 2023. We are still ongoing, and we are planning to end around March 2026. By way of contents of the presentation, we'll look at the background, study objectives, methods that were used for the research, results, where we are currently, our next steps, and any acknowledgement. By way of background, Ghana achieved its targets of eliminating global leprosy as a public health problem back in 1998, when we went below a prevalence of 1 per 10,000 population. Despite that, we have recently been having cases from 250 to 280 annually, which is coupled with consistent high MB proportion of those case numbers, with an increased grade 2 disability rate, which is evidenced by last year's 15.1%. But we've been able to keep our child proportion as low around 3% and lower. And we also have gaps in terms of our early diagnosis, which affect or gives us more deformities in our cases, which creates stigma with our patients, and also have issues with our treatment adherence. We believe that building a positive peer mentorship system would provide a system to reduce these issues in terms of the early case detection, reduce our stigma, and also support our patients with emotional support. Okay. All right. In terms of study objectives, we want to understand the role of persons affected by leprosy in engaging new and suspected cases in our community. We want to see how they can best support our case detection referral and improve our health-seeking behavior, develop a model with the feedback from those two areas to come out with a system where we'll implement in our community to help reduce issues with stigma. With our study phases, we have 4 phases. Currently, we've completed the first phase where we interviewed 2 groups of people, our persons affected by leprosy, who are the mentors, and our healthcare workers who are actually taking care of the patients. For the phase 2, where we are currently at, we interviewed our newly diagnosed patient with our mentees. We also linked them to our mentors. We interviewed those also. We assessed facilities for their readiness to receive those cases also. For the phase 3, we use the feedback from phase 1, phase 2 to plan workshops where we take feedback from our stakeholders, come up with a model which would implement in the phase 4. Methods that were used, study sites. So we used the Upper West region and the Ashanti region based on our caseload for the past 3 years, which ranges from 2021 to 2023. And we are using the study design of combining qualitative and quantitative design methods. Our participants that we've used are the peer mentors who are the persons affected by leprosy referring other suspected cases, our mentees, newly diagnosed persons affected by leprosy, and our health facility heads when we are assessing the facility, and the leprosy focal persons when we wanted to see the healthcare workers actually taking care of our patients. In terms of the data collection, our key informant interviews, we looked at 23 persons affected by leprosy, 39 healthcare workers. But before then, we always seek verbal and signed consent before the interviews. We also assessed 61 health facilities on the readiness and capacity support of peer mentorship. We also, in terms of the mentors, 22 mentors had their CAP, which is the knowledge, attitude, and practices related to leprosy and peer mentorship assessed. We also assessed 31 mentees for their case detection delay issues. In terms of the preliminary results for phase 1, where we are looking at the 2 groups of existing mentors and the healthcare workers, we wanted to understand how they were being referred to the facility. So we learned that 26% of them were being referred passively to the facility, meaning they were going themselves. 13% were being referred by other affected persons, which means that the peer mentor system already is in place. 61% were being referred by other modes of referral, which is the family, the healthcare workers, the community members. We also learned from the interview that 91% of them had seen people with similar condition of leprosy in their communities. They were all interested to help in the case set and referral, and very importantly, 48% of the persons affected by leprosy indicated that they have experienced stigma, especially with social exclusion. We wanted to also understand the motivation for referring persons to the facility, and we learned from them that they know the science and the symptoms because they have a lived experience and they have a desire to reduce suffering for others. They want to encourage hope that the disease can be treated. They have a good feeling of wanting to refer patients to the facility, and they have a desire to engage. We have a few quotes, direct quotes from the patient that we have in the box at the right side of the screen. I'll read one of them. Knowledge of disease. As it has happened to me, I know the physical signs, and anytime I see the symptoms in someone, I'm able to know it's leprosy. So when I see someone with that condition, I advise him or her to go to the hospital. So this is the direct quote from a patient which was interviewed. We also wanted to know some of the challenges that they face in their community and in terms of treatment. And they talked about the perception of the condition for community members. They also spoke about the logistics for reaching others. For those cases that they've suspected how to reach them in the community, there's distance issue, there's financial issue in meeting them. They also gave some suggestions on how to reduce stigma in their community, and they spoke on we having to provide education on signs and symptoms of the condition, education on the transmission and how susceptible people are to getting leprosy, education on the treatment and case management also. In terms of the other group, which is the healthcare workers, we tried to look at how or when frequent, how frequent they've seen cases in their facility. So realize that 33% of healthcare workers interviewed have seen cases in the last 1 year. 34% of them have seen cases between 1 to 4 years in their facility. 33% have seen cases 5 years and older. We also learned that 45% of healthcare workers have not received leprosy-specific training. So since they've been in the facility, they've not had any leprosy training. And 1/3 of them had seen persons affected referring suspected cases to the facility. So they've seen the system already being in place in some form. They shared some challenges also, and they spoke about the stigma in the system itself, the stigma in the community, stigma between the patients and the community, social inclusion and all those. They spoke about the distances from the communities to the facility for treatment. They spoke about the financial constraints of the patient moving to the facility, even though the drugs itself is free. They also spoke of limited health worker knowledge, which we shared because of the percentage. You realize that even if you refer a case to the facility, for the patient to be, or for the suspected person to be diagnosed, we need knowledge. So there's limited health worker knowledge on that. There's always also the belief and the misconception on the condition also. In terms of the conclusion and next steps, now, we believe that the peer mentorship is a promising strategy for enhancing leprosy care and stigma reduction, and formalizing this structured approach would address operational challenges that we have and would crucially help in sustaining and scaling it up. Our next steps is to complete the phase 2 analysis, use the phase 1 and phase 2 feedback with stakeholder feedback to come out with a structured and formalized model, which would implement and integrate into our existing health system. We would want to seriously acknowledge support from Leprosy Research Initiative, St. Francis Leprosy Guild, Hope Rises International, formerly known as American Leprosy Missions, our Ghana Health Service Leadership, our National Leprosy Control Program, headquarters staff, Upper West Region, Ashanti Region Senior Health Management Team, our coordinators, district directors, health staff, and very importantly, our patients. Thank you very much.
Thank you for your presentation. I don't think there were, there's one question I think.
Yeah, just popped up indeed. Saying, thank you for highlighting the role of peer champions in your research. Did your findings reveal anything about the effectiveness of female peers specifically? How do you see their role in supporting early detection, care, and stigma reduction, especially among women and girls in their community?
Thank you very much for the question. Based on the participants that we had in phase 1 already in analysis, we had a few females involved, and based on analysis, we realized that they were eager to help. And because of the fact that they were women and they had that emotional connection with people, they were able to actually refer more cases to the facilities. So we believe that having more females in this system would really help us because they had that easy nature to get closer to patients more than males. That is what we have in our system. So we believe that having more females would help us.
Mm-hmm. And I know that from one other project that where peers were engaged, there was a challenge for the women to with their mobility. Did you face that at all in with the female peers in your project?
Yeah. No, I think it's a generalized issue because of where the patients are staying. Most of them are in rural areas. So moving from where they stay to where the facility is a challenge already. So it's not just the female, it's a generalized issue that we need to look at. So during the phase 4 where we roll out the model itself, we need to see how we support them in moving to where the suspected cases are, moving to the facility, following up with the cases to make sure that they don't default and they follow up with the treatment.
Thank you.
Any other questions?
There's one more, and that's just thank you for your answers. They are useful.
I was wondering because I can imagine that some of the persons affected by leprosy here, which can be a key that can play a key role, but it differs from personality also. The one is more relaxed in approaching another person than the other. Are you also looking into what personality factors may play a role? Which one is better than the other? Because it's still an obstacle to approach somebody who might be affected by leprosy. Huh?
Okay, all right. So it didn't come up per se individually, their perception, but what we learned for analysis was most of them were eager to help us with it. Their problem was the misconception on the condition itself. So if you look at some of the quotes that we had, some of them were saying that if you go to somebody's house and you try to suspect the person of the condition, and if the person is diagnosed with leprosy later on, you as the person who went into the house now becomes the one that actually you brought the condition to the person, because they don't believe that leprosy is actually a condition that we are treating. They believe it's just a past condition, a condition that is gone. Yeah. So they have those issues with the beliefs and the misconception, which we are really working on with education in our system, so that whatever activity that we do, we try to add awareness into our activities to bridge some of these gaps.
And if I may ask another question.
Yes.
The other way around, I can imagine that a person who just might be infected by leprosy, who got the diagnosis, he sees somebody entering his house, but this person might be known in the region of
yes,
in the area as the one who was affected by leprosy in the past. So
yes,
can't there be any dynamics, a negative dynamic, that a person wouldn't let this person in?
So for communities that they've accepted the condition itself, so we have communities that they have accepted that, oh, leprosy is treated. Then you know that, okay, this person is a mentor who, if you suspect any skin lesion that looks like leprosy, you can call to come in and help you. It's a different situation. But where the condition is not accepted, and if you have a suspected case and you have to call somebody who is not accepted in the community, this is where we have issues like this coming in, where the person will come and suspect the case, and then if it's diagnosed, you would have some issues with them.
Thank you.
Yes.
So we continue, Wim, or do you have something?
Yeah, I think so. There's one question about traditional beliefs, but I think that would be an interesting question perhaps to take at the end when we have the more general discussion.
Okay. Right. Then we continue with Abdullahi, who is presenting a study from Nigeria, a collaborative code designed to optimize evidence-based and contextual general health workers training in integrating screening for leprosy and other skin NTDs in Nigeria. Please go ahead.
Good afternoon, good evening, good morning, as the case may be. I am Suleiman Hudu Abdullahi, and greeting you from Nigeria. I will be presenting our research project titled Collaborative Co-Design to Optimize Evidence-Based Contextual General Healthcare Workers Training in Integrated Screening for Leprosy and other skin disease conditions. So the background. Nigeria contributes to estimated 1/4 of global NTD burden and substantial contribution in leprosy burden. And despite this huge burden, there is a huge gap in dermatologists, that the specialists that provide health skin care, with only one dermatology per 1.6 million population, indicating a very huge gap compared to many other underdeveloped countries. So according to the WHO, the training of general health care workers is needed for us to achieve the global target for the roadmap 2021-2030. So if we are to achieve, we have to also focus more attention on building the capacity of the general healthcare workers. For our research work, we realized that there are very limited evidence on co-creation, and also its role in developing the effective training for integrated skin diseases. So we aim to find out and also to generate evidence on these two areas. So our work is in line with the global NTD roadmap, both the operational research priorities and also program priorities, which include evaluation of trainings and also the training materials. Traditionally, we do train, but there are very limited evidence on how effective are those trainings, because the evaluation methodologies are very limited, particularly with regard to skin NTDs. And also the program priority, which involve development of training materials for general healthcare workers, and also it involved the aspects of clinical diagnosis, treatment, and morbidity management. So these are our research questions and the research objectives. We want to find out how can the co-design be used to create evidence-based contextual, that's based on the context, for the training of integrated skin diseases with main focus for leprosy for general healthcare workers. So the objective is to collaboratively co-design, collaboratively co-creating an evidence-based general healthcare workers training in integrated skin NTD screening with focus on leprosy, but using the digital health technology, as we are now recognizing the importance of digital health in the control of diseases. The second objective, to identify recommendation for designing and the evaluation of contextualized general healthcare workers training on integrated skin screening. There has been trainings, there has been particularly on single NTDs, but not much evidence are available on this integrated skin screening. So, and we also want to find factors that are most important to different stakeholders in designing the educational training. So as a shift from the traditional way, this time we want to put the stakeholders to bring their experience and to bring their ideas, and we want to find out what is more important to them to help us develop the products. And we are also to do literature review on the training, which is first step of our implementation. We have realized that there is no evidence as far as systematic review is concerned on the available evidence on the integrated training for skin diseases for the general healthcare workers. So it's a mixed model study, predominantly qualitative, with 3 different phases. The first one is pre-development, which will include the systematic review. We have done the systematic review with more than 5,000 articles screened by title and abstract, and we got around 64 that are eligible for full text screening. And now we are working on 46 that we already got the full text, and we are doing the data extraction and the analysis. So the next step is to do the workshop. Based on the evidence, we'll gather all the stakeholders, and we will develop the training program. And in phase 2, we are going to use the products that we developed to train general healthcare workers. And we are also going to assess the impact of that training program. Not only using the traditional pre and post test, but we are going to use other, methodologies, framework that are used for evaluation of trainings, like the Kirkpatrick model. So we are also going to do the post-development phase, which will include interviews, data analysis, and we'll write our research work and publish with the wider NTD communities. So this is our systematic review, which we have done, which is evidence on the general healthcare workers training on integrated skin NTD and the common dermatological conditions. This is the research question. What is the impact of capacity building, training, and learning approach on the ability of general healthcare workers to provide integrated skin disease screening? So we are going to answer discussion with our systematic review and use the evidence to design the training program using co-creation approach. So the study will take place in Nigeria, in Kano State, which is one of the highest burden leprosy and NTD states in Nigeria. We are going to also involve various stakeholders, including the healthcare workers themselves, persons affected, dermatologists, NTD program managers, medical education experts, medical educators, to be part of the co-creation workshop to develop the training. And we will also do the data collection of the creation of the workshop, a kind of comprehensive to collect to record all the events during the training so that thematic analysis can be done. We will also do the post-training test, and also we'll do interview, and we are also going to do on-the-job observation as a shift from the traditional way after the pre and post test. That's all. But we are going to do the observation, which is part of the Kirkpatrick model. So the co-creation. The co-creation is will be evidence-based, based on the systematic review, and it will involve all the stakeholders that we mentioned earlier. So everyone will have an equal say, working together just without favoring one knowledge or the other. So that's how we are going to develop the training product. And we'll get to, have more insights on that encourage participation in co-creation environment. So we have the stakeholders who will take into consideration social, political, economic context, and we are also going to take cultural and behavioral context. That's what make it contextualized. So we are going to use also the digital technology, particularly the WHO NLR skin disease, and some other innovation as part of the tools that we will use to develop the training program. So progress so far, we have all the preparatory work. We have done the scope review, and we are now at the stage of doing the co-creation workshop, which will be conducted 22nd, 23rd April 2025. stakeholders were engaged even at the preparatory stage of the workshop, including development of the program. So what next? To finalize the scoping review and also to develop the article, and then to do the co-creation workshop, and we will do the training of the general healthcare workers in June. So what are the challenges? So some of the challenges include some of the, process that we have passed through by changing, affiliation institution. But thanks to the support of the mentors of the projects and the RedAid Nigeria, we are really making very significant progress in this. And also Nigeria is facing very high inflation and cost of living, which could affect the initial budgets. But we are also having a kind of favorable exchange rate, which is filling the gap of high cost of living. And then during the workshop, we fear that some might dominate others, like when we have program managers at the highest level and general healthcare workers at the lowest level, they may not be able to express themselves. But we are critically working with the stakeholders to identify the best ways to enable everyone to express their, opinion, and to also come up with their experience. So what are the impacts? So the evidence generated in this study will provide insights.
Can you round up, Suleiman, because we
will
well over
provide
time.
insights into the training requirement when task shifting in dermatology in Nigeria, and will disseminate the lessons we learn into various platforms, and also will publish the findings and the products at Info NTD, and also will work closely with the leprosy learning projects, so to ensure wider application. So these are the acknowledgements. Thanks to the Leprosy Research Initiative, then RedAid Nigeria, the hosting institution, the mentors, and the LTR, McGill's University, Kano State Ministry and of Health, NLR, and the Federal Ministry of Health Nigeria. Thank you.
Thank you, Suleiman. Should we continue with questions, Wim? Do you have some of them?
Yes, I don't have any question on the last presentation yet. Thank you, Suleiman, for a very comprehensive presentation. We still have a question from Johanna Abdu. I think that was to the second presentation, but perhaps it is also relevant to the first. And so feel free, Joydeepa, to also chip in if you want. The question is, were you able to register challenges due to traditional beliefs? So, Frederick, you want to comment on that? Did you?
Okay, all right. So, yes, we're able to pick up such challenges with both of the groups that we interviewed. And so most of the community members, because they are mostly staying at the rural areas, they believe that leprosy is caused by curses and spiritual forces, not the bacterium that we know. And this belief also affects or leads to delays in seeking care. These people sometimes they have to seek help from traditional leaders, some homes and all those things before they come into the facility. So by the time sometimes they will come, they have deformities already, which always creates stigma. There's always that problem also with the misconceptions about referral treatment being more difficult and all those things. So during the analysis, we found such situations.
Mm-hmm. Thank you.
I have a question for Suleiman on his study. So if I understand, these general health workers will be upgraded with their dermatological knowledge, huh? As part of an intervention. What I'm wondering, the knowledge, they have to do it beside their normal work, and sometimes the surrounding of these general health workers, these general health systems, they sometimes have the negative image of that they don't know much about leprosy. Do you also put some effort in making clear that this knowledge is available in these healthcare systems, in these healthcare settings?
Yeah, so thank you very much. Based on experience and the evidence we are gathering over years, we recognize that these healthcare workers, they are actually the one providing this care, whether with knowledge or no knowledge. So they provide the care. For example, an average general healthcare worker in a rural area, he is the dermatologist, he is the gynecologist, he is the infectious disease expert. Whether you build their capacity or not, they will provide the care. So building their capacity in area related to dermatology, though limiting the number of diseases, focusing on skin NTDs, will not add so much burden to their work, but helping them to do it better and also to detect the cases earlier. We haven't seen any kind of indication of too much burden, but rather a kind of a passion, you know, to know more about it. Because before we are going for leprosy only, but when we introduced other skin diseases in addition to leprosy, that's other NTDs, we have realized that the interest has risen among you know, the healthcare workers that are involved, especially for the RedAid projects that we implemented in Nigeria.
Yeah.
Thank you.
There's one other question now. How Dr. Suleiman is planning dissemination of results for other stakeholders in other states and countries to that might benefit from that. That may be a bit early at the states that your project is in, but do you have plans for that already, for dissemination?
Yes. For example, we will write peer review articles, which we will publish in peer review journals. In addition, we are also trying to reach as many forums as possible. Currently, we are also, you know, submitting just the general overview of the work that we are planning to do to one of the NTD forums in Africa. So we will write on different aspects of the project. For example, when we finish the scoping review, we will disseminate the findings on the general NTD, skin NTD integrated screening, and even evidence on the type of capacity trainings on this field. We will also publish the co-creation workshop, the processes that we have passed through, the lessons that we have learned. And also, when we finished, we will develop the evaluation you know, model, where they have been used in other aspects of trainings, like in disaster management, but it has never been, you know, used in the area of skin training, particularly even the neglected tropical diseases. So this is our plan for the dissemination.
Do you have any opportunity for, say, what you're describing is mainly about sort of written dissemination, which is of course very important. But I would imagine that a lot of the peers of the people that you're training, and that they may not be regularly reading any published studies or and so are there any say meetings, either quarterly or annual meetings or so, where you could speak about it?
Yeah. One of the very important stakeholders that we are currently engaging are the association of the persons affected. For example, we have discussed with the persons affected by leprosy, persons affected by Bruley ulcer, their organizations in Nigeria, and they have so much welcomed the idea. And we have reached out to also the global scheme. So we will use also their channels to make sure that the findings we have disseminated. And for the general healthcare workers, who will be, involved in like a CME meetings, or if there are some opportunities to do the training, and also invitation of the we call them School of Hygienes, who are training this general healthcare workers, so that to get their buy-in. So if we develop these products, they will also be integrated into their own, training programs. Also, the National Training Center. So by also engaging them to be part of this, so the information we got through this can be also disseminated to the wider, communities beyond the traditional scientific one.
Mm-hmm. Mm-hmm. Thank you. Yeah. There was one comment here, which I would like to take a bit more general. It says personality of persons affected by leprosy and their role in the community also affect in dealing with stigma at household and community level, as pointed out by Dr. Eric Slim. I was wondering, particular Frederick, whether you have, so when you select people who can be active as peers, whether you use any selection criteria, because at least in our experience, not everyone is suited to such a task or interested even in doing that. So how about in your project?
Okay, so for the phase one, when we're selecting the persons affected by leprosy, we just based it on the participants that have referred patients before. So they should have an experience of referring patients to the facility. They should also be cured patients. They should have gone through the process of the treatment, whether MB 12 months, PB 6 months, for some years.
Mm-hmm.
And they should be willing to be part of the system itself. Yes.
Yeah.
So those were the things that we used for the selection criteria. We didn't have any extra things to look at. Yes.
Mm. Yeah, I guess especially that last point, the willingness and the interest that would kind of self-select people who are interested to go out and do things, right?
Yes, please. Yes, please.
Yeah. I don't think we have any further questions, Eric. So
Yes. Okay. Shall we round up then?
I think so, yes. We
Yes.
have some time to get back to the final session.
Yes. Well, I'd like to thank the three speakers for their excellent presentations, very interesting. And of course, I would like to thank also Wim van Brakel to be the co-chair today. And I hope you enjoyed the LRI meeting yesterday also and today. And I wish you all the best.